wires, and a refresher on pacing in general, because a lot of times when this procedure needs to be done, it's an emergency and everyone is very stressed out, obviously, and it's not done by most people that often. So when it needs to be done, it's usually somebody's life or death situation here, and you really only have a lot of times minutes to get it done. So this was kind of a refresher course in terms of how the procedure is done, what is the difference in pacing and sensing, and then our protocol on how to get one put in, basically, that we just recently changed, and then finally, who needs it, basically, okay? So this is all for temp wires. No work, good luck.
No, but I have it in my phone here.
That's fine, I can just draw on board. So first, just some basic principles of pacing. I know a lot of people get kind of confused by pacing, but it's really not that confusing if you kind of just break it down to some basics. So a pacemaker's function is basically two things, right? It has to be able to sense what your heart rhythm is doing on its own, and then what we call inhibit. So if it sees your heartbeat, it needs to stop itself from firing. It shouldn't fire when your heart is beating, so we call that the ability to sense and inhibit. And then the other option is to be able to pace. So if your heart doesn't beat, it needs to pace. So a pacemaker is just a series of very complex timers, maybe 15 or so timers, of which I can set all of them to be able to synchronize the heart rhythm. So when you're talking about putting a pacemaker in, I'm just going to draw up here for a second. So if you've got a P wave, and then a QRS, and then a T wave, you need the device to be able to, and we're just going to talk about single chamber pacemakers. So by single chamber pacemaker, I mean ventricular pacemakers. So we needed to be able to see a QRS complex, okay? And obviously, it's not going to see a P wave as long as you're in the ventricle with the pacemaker, because a P wave does not exist in the ventricle, in the intracardiacs. And a T wave doesn't really exist really either, intracardiac-wise. So a T wave is a repolarization abnormality that you see on the surface electrocardiogram, and you don't see intracardiac. So we don't really see the T wave either when we're intracardiac. So the pacemaker's ability is basically to be able to see, oops, that's not wrong. You want it to be able to see the QRS complex, but not see anything else for the most part, okay? It's very different than defibrillators, where you want to see everything, okay? Because a defibrillator needs to see ventricular fibrillation, which is very, very small signals. So a pacemaker just needs to be able to see a big spike, which is the QRS, okay? So we call that sensing. So when you need to adjust the pacemaker, we adjust something called the sensitivity, okay? And that's one of the things that's on here. There's going to be 3 things on this temp wire. It's going to be how fast you want it, we call that the rate, the output, how much energy it's putting out to be able to actually make the heartbeat, and then the sensitivity. There's a lot of confusion in when we talk about sensitivity. So we say either increase sensitivity, okay? So increase sensitivity means make it ability to see things better. So you want it to be able to see things better. So if you talk about this as a fence, okay? So if this is the fence here, that's my fence, right? So whenever I talk about changing sensitivity, I'm talking about whether we raise the fence or lower the fence, okay? So if I want to increase sensitivity, meaning I want to be able to see things better, then I'm going to lower the fence, right? So you decrease the number. So increasing sensitivity on this actually is decreasing the number, because the number is basically how tall is that fence. So if I want to be able to see more, then I need to decrease it. But let's say I don't want to see anything, okay? I just want the pacemaker to function at a certain rate. I don't want it to ever look for the person's own heartbeat. Then I want to decrease the sensitivity, which means raise the number, okay? So I can get to the point where it doesn't see anything. Even though the heartbeat is there, it's not seeing it at all, okay? Or I can drop it so low that, then you can have problems with, if you jiggle the wire a little bit, it will think that's its heartbeat as well. So you want kind of a perfect range. Normally that runs, when I set them on people's permanent devices, usually around a number about 5 or so. That's what we set them permanently at. So that's one of the parameters on here, that's sensitivity. The second parameter is output, so how much energy does it actually take. So it's going to default at 10 volts. That's a ton of energy. That is a ton of energy. But to give you a frame of reference in comparison to an ICD, the amount of energy a pacemaker puts out is about 1/10,000th of amount of energy as an ICD puts out when it shocks. So that's why you can never really ever feel a pacemaker when it's going off, okay? You could even touch the end of it and you wouldn't really feel anything because it's such a small amount of energy. Versus an ICD, obviously, if you were holding on to it, actually onto the lead itself, you could feel that. You can never get shocked by an ICD, by the way, just as a side note. I hold on to them all the time when we're testing them in the operating room, standing right next to the patient. You cannot get shocked by one. You can't even get shocked by a defibrillator. When I'm doing a cardioversion, I routinely push on the pad with my hand with a glove on, and you can't get shocked by them either. So that's kind of a myth that electrophysiologists have tried to move out of people, that you have to worry always about getting shocked, basically. And you get these people who say, I heard somebody got shocked by one. That's just urban myth, basically. But they even did a study. It was published in one of the EP journals that you really can't get shocked. Because remember, electricity is lazy, so it's going to go to whatever's the easiest thing. So what's easier? 2 pads on somebody's chest going through basically water, because that's what our body is, or going from their body through my gloved rubber hand, through my body, through the soles of my shoes to the ground. That is a lot harder for electricity to do. So it's really not going to do that. Now, I'm not advocating for you guys to sit there while doing CPR and still stay on, but it's just kind of an FYI. So ICDs can never shock you. So as I was saying, the second parameter is output of the device. It's going to start at 10 volts. Permanently on pacemakers, I usually set them around 2.5. But ideally, we want numbers less than 1 would be great, okay? But, so if you're in the range of 2.5, that's pretty good already, okay? So those are the 3 parameters. The rate, you're going to set it at, the sensitivity, which is how high or low the fence is, and then how much energy it takes. So those are the basic principles of pacing. Does anyone have any questions about that? No? Okay, great. There's also a principle of what we call overdrive pacing. So your heart's going to listen to whatever's the fastest heart rhythm. So if your heartbeat is 60 and I pace you at 80, your heart's going to listen to the pacemaker, okay? And sometimes we use them for people who are having lots of arrhythmias. We can actually do what we call overdrive pacing on those people. So they're having lots of ectopy and arrhythmias. We can pace them very fast at like 100, 110, and we can suppress those rhythms. So that's the second part, okay? So now let's talk about actually how the device goes in. So it's very similar to putting a Swan catheter in, if anyone's ever put in a Swan catheter, or just putting a central line in is the first step. So obviously the first step of putting one in is to get your access. So anatomically, you're going to want one of 2 different positions. So you're mostly doing this blind, basically. So you want as straight of a shot down to the heart as possible. So if the RV is sitting right about here, and you have options to go either through the right subclavian, the left subclavian, the left IJ, or the right IJ, well, the straightest shots are going to be from the right IJ, which goes straight down, and then it's just a small curve across the tricuspid valve into the RV. Or from the left subclavian, you'll follow the whole vein down towards the superior vena cava and then into the RV. So if you come from the right subclavian, you're going to have to kind of come down at the SVC junction with the right axillary, and you're going to have to make a sharp kind of turn down to the right. That's very hard to do. It's not going to want to go that way. So it's going to want to try to go down to the left arm. So it's much easier to come from this side. And then same thing from the IJ. The IJ, you kind of have to cut down the IJ, and then there's a kind of weird turn, corkscrew turn, where the IJ connects into the axillary and then dumps into the SVC. That's also hard to do as well. So preferable places are right IJ and left subclavian. So basically, you just put a central line in. We have the kits here. They're the 6 French, or ideally 5 French if you can find one. Introduce your kit. So you just put it in the exact same way you'd normally put it in, modified cell-dealing approach. Stick the IJ, stick the subclavian, get your access. So once you have the sheath in, you're generally going to want to take another sterile towel and kind of cover up all the mess that has been made, because these are emergencies often, so it's not always perfectly sterile. So I usually take another towel and put it over top of that. That way, at least the temporary wire that's going in, that's sitting inside the heart, that's the most exposed, is at least the most sterile part of the whole procedure if you can, okay? So the best thing to do is have at least one assistant, and in general, when these things are going in, you're going to have like 17 people in the room helping you, because it's kind of chaotic and all hell's breaking loose at that time. So you want to have at least one other person, potentially two other people, to help you put it in. So the main operator is going to have basically, this is the patient, and I guess this would be, it's kind of the wrong direction, but but this would be your access here. So what you'll do is you'll have your assistant hand you the temp wire. So that's the temp wire. It's okay if I open that? Okay. So the temp wire kit includes a few things that you don't need and a few things you really need. The first part is this syringe. So this syringe is got a little stop on it to only be able to drop 1.5 cc's. And the reason that is because the balloon is exactly filled for 1.5 cc's of air. So if you were to lose this, not ideal, then you only want to blow up cc and a half, 1.5 cc's of air into that balloon because you could cause the balloon to rupture. Everybody always checks the balloon. That's fine. I've never seen a balloon not inflate. So you would just kind of pull up your cc and a half, put it on there. And this end will blow up. Or not.
It might be outdated.
Oh, okay. There you go. So this one did blow up. So normally the balloon goes up, which is a good thing. And then what you want to do is you want to allow this to passively deflate. So you push it down here, and then if you just let go, this thing will automatically slowly come back out again. So the best thing to do is to kind of just let it passively deflate. And when you inflate, you want to do it slowly, obviously not to put too much pressure on the balloon. So once you know that works, you basically are going to have two ends. This is going to be the operator's end, and this is going to be the non-sterile end, although at first it's all sterile. There's a lot of stuff in here that you don't need. You don't need these little clips anymore. We have new kits that don't, new pacing boxes that don't need these. And they give you, I guess this is an access needle, but you don't need that either. So those can basically be tossed. So what you're going to do is you're going to take one end, and whoever is your first assistant, you're going to pass it off to them, and you're going to say, this is the non-sterile end, and you're going to hand it to them, okay? The second end is going to be yours to keep, and then you're also going to get, in this introducer kit, is a couple other things you need. One is this is the swan dome, we call it, okay? This is the thing to keep it sterile. So you're going to want to always remember to put this thing on, because that's the most common mistake, is that people put the temporary wire in, and they forgot to put this on, and once this is in, you can't put this over top of it. So you want to always remember, that's why as soon as somebody hands off the temp wire, I say, where is the swan dome? Put it like right in front of the patient, basically, so you know to put it on, because once it's in, often they immediately become dependent on the pacemaker, and then there's nothing you can do about it, basically. Then that's a lot of tegaderm to cover up the whole wire, basically. So two ends to this. There's going to be the end that connects to the catheter itself, which is down here, and then the other end. So you're just going to pass this through here, just like so.
Make sure you put it on the right direction.
Yes, you definitely want the cap at the right end, and then that goes all the way down, and you just bring it all the way to the top, and then you can still pass that off to the non-sterile person. The non-sterile person, which is going to be most of the time an ER nurse or such, is going to take this end. They're going to take this. That's what I was looking for. So this is the connection. Do you want to help?
Yeah, want me to hear it now?
Sure. So they're going to take this end, which is the wires, and it's got these little alligator kind of clip thingamajiggies, and then that's the end that's going to connect into the pacing box itself. So this, where's my template again? Here. There it is. So this is going to have two markers on it. Oh, actually, one's going to have the marker. You can see it on this side.
It's on the wire.
Oh, there it is. Okay. So one's going to say distal, another one's not going to say anything, and it's going to have distal negative, so that goes straight into the negative. You kind of have to push relatively hard. There it goes, and you'll feel a click. And the second one, click. And then this thing is to prevent people from pulling them out. So you kind of leave a little on here. And I don't usually do this part, so. And then that kind of clips on like so. So that way people can't pull them out, basically, out there, okay? So that whole end, the non-sterile person has, thank you. And then what they're going to do is they're going to take the temporary pacer box, and they're going to turn it on, obviously. And then the initial settings are going to always be a heart rate of 80, an output of 10, and a sensitivity of 2 millivolts. That's fine. So I generally don't connect it right this second. I wait until this is at least in a little bit first. So the operator who's going to be putting it in, if you notice this has got a nice curve to it, and the curve is designed that way, so that way if I'm coming from the right IJ here, see how it goes towards my heart? Or if I'm coming from the left subclavian, it still goes towards my heart. Versus if I'm coming from this direction, it wants to turn that way, or it wants to go towards my right arm, it's not so good, right? So this curvature is your friend, okay? So this is really important to maintain that curvature, and when you're putting it in, you want to make sure that you're putting it in so the curvature moves towards the heart. So when I'm going in from the neck here, I want to make sure this curvature goes like that. I want to make sure I don't flip it this direction, and the curvature goes that way, otherwise you're going to have a hard time getting it in, obviously, because you're doing it without any fluoro.
He's changed him around. He's in the wrong direction.
He's in the wrong direction, that's okay.
Yep, change the
Yeah, I'll
table around.
put him on that side. There we go. Get that, there you go. Perfect. Okay, so let's imagine this is a right IJ and the patient's over here. So basically, all you're going to do is you're going to insert it through this hub here, like that. I'm not going to go all the way because it's not going to go anywhere. But the line has got markers on it. Small markers are 10 centimeters, and then there's a fat marker here, which is 50 centimeters. So you go into around 20 centimeters or so, which is 2 lines. And at that point, the end of the catheter should be outside the sheath. So that way you can safely inflate the balloon. So then you tell your operator, go ahead and inflate the balloon. They'll inflate the balloon. And this is not a lot of science here, but you basically just push. And you're going to watch the EKG, obviously, at this point. So you need to have a monitor up, and you're going to often have a life pack as well, because sometimes they're transcutaneously pacing as well. And you're basically going to just kind of try and push, not slowly, but probably at speed like around like this or so, because you want to use the balloon and the force of the blood moving through the heart to be able to basically get into the RV. And what you're looking for on the EKG is what looks like a wide, complex pace rhythm. And all of a sudden the rate's going to change. You might see a couple PVCs first, but as soon as you see a pace rhythm, basically what I do is I stop, and then I tell the operator, the assistant, to drop the balloon, and then very carefully I push it in maybe another half a centimeter or so, just a tiny, tiny bit. Because what you're really trying to do is you're trying to get that thing, which is probably trying to float right here at the RV apex, and you're trying to get it to drop just a little bit and settle right at the bottom of the heart. That way it's nice and stable in that position. A lot of times people will get stuck at the tricuspid annulus, and they'll get capture right across the tricuspid valve, and then they won't move it at all. And those will dislodge fairly easily because that night it's sitting right at the tricuspid valve and it's not making good contact, and they'll dislodge in the middle of the night. So that's one of the most common things I see when I bring them down to the lab. I actually floor it. I see it sitting right at the tricuspid valve, and it's not in far enough, basically. So as soon as you see the capture, then what you're going to do is you're going to have your first assistant assess how good of a position you have. So obviously this is connected at that point. You don't have to connect, that's fine. So the first thing you're going to want to do is drop down the output. So how much energy is it actually taking to capture the heart? So I remember I told you it starts at 10 volts. You want to bring it down slowly. It's going to drop by, I think, half volts at a time. It drops at full volts at a time, and then it drops down by half, and then eventually drops down by 0.1s. So you want to bring it down until you no longer see capture on the EKG or on the life pack or whatever it is. And we'll get into it in just a second what you do if you've got somebody who's already paced on the transcutaneous as well. It gets a little more complicated. And then once you see that's working, so you know what you call your capture threshold. So let's say you lose capture at 2 volts. You say 2 volts is your capture threshold. And then you want to set it to at least 2 times that. So if you get capture 2, you want to set it to at least 4. And remember, these things are not going to run out of battery overnight. We're not talking about long-term pacemakers that you want to conserve battery on. You could set it to 10 volts if you wanted to. You could set it to 5 volts, at least 2 times threshold. That's what we say. But you don't have to worry about this running out of battery overnight, basically. So once you have that, then the question is sensitivity. Sensitivity is probably one of those things I probably wouldn't mess with too much. I'd probably just leave it on the base settings of 2. Unless you wanted, unless somebody's got a very, an intermittent slow rhythm, and you want it to sometimes sense and sometimes pace, then what you'd have to do is you'd have to basically make it more sensitive, so bring it all the way down, the number all the way down, and then slowly make it less sensitive, until it no longer is seeing the heart rhythm and just pacing all the time. It gets a lot more complicated to start doing that if you're not familiar with EP. So I usually tell people just leave it at 2 millivolts. That's usually good enough. To give you an idea, when we put these in the lab, the numbers that we're usually getting for how big that spike is are usually 5, 7, 9, 10, those numbers. So if you've got this set at 2, you should easily be able to see a spike, basically. So after that, you basically lock this up, hang it from the bedside usually, and then you want to secure all this. So you slide this down all the way, and remember, this can move at this point, so you want to keep your finger here and just carefully slide this down all the way to the end. Usually I just kind of have somebody hold one end, and I slowly bring it down until it's at the very end. There we go. And then it locks on place, like that. And then for securing in the ER and up in the ICU, usually what I do is I make a loop like this, and then I put a stitch on the skin here, and then I actually tie the wire down like this. That way the patient themselves can't really tug it out for the most part. And then you obviously secure the sheath down as well. And that's how you put them in. Obviously, this is a lot simpler when you're doing it here and not when the patient's got pulse of 10 and somebody's trying to intermittently do CPR. Ideally, if you're in that situation, you have to do CPR while you're putting them in. Yeah. You ideally hold CPR in the meantime while you're trying to actually push it in, because it makes it a lot harder to get these in when you're trying to actively do CPR. So remember, a pulse of 10, it's not ideal, but for a few seconds, 20, 30 seconds, it's still a pulse of 10. So just imagine when somebody arrests on the floor, the amount of time it takes us for getting to that patient to start doing CPR. If it was only 30 seconds, that would be wonderful, but most of the time it's much longer than 30 seconds. So when people hold CPR to try and get a temp wire in real quick, it seems like forever they have no pulse. But try your hardest to not do CPR while you're putting one in, because it makes it much more difficult to assess when you've got capture. And then remember, if you do put one in and you've got capture, you have to still check for a pulse. Okay, because just because you've got electrical capture doesn't mean you have mechanical capture. So if you don't have a pulse and you just see a pace beat, that's not good. Obviously, that's PEA at that point. So then you just do ACLS like PEA anyway, and you assess whether or not, is there something wrong with the pacemaker? Is there some other reason, aka hyperkalemia? That's the one that I've taken 2 or 3 people to the lab for, and I put real devices in them emergently, and I can't get capture either. If the potassium is 7 or 8, it doesn't matter how much electricity you give the heart, you're never going to get a pulse with that, basically. So that's these aspects.
Eric,
yeah.
Question. Mm-hmm. So insertion complications, things to look out for?
The biggest one is perforation. So when you put one of these in, these are stiff. Now obviously with the balloon up, it kind of makes a softer area. But if you push too hard, you can clearly perforate. You're not going to feel the heart when you're in there. It's not like you can feel resistance for the most part. So in fact, having a temp wire in is one of the leading risks of developing a perf when I put a permanent device in. So if somebody already has a temp wire in there and I have to put a permanent device in, they have a very high risk of perforations at that point, because you basically preconditioned the RV with something that's already sitting there and irritated it. So when I put my lead in, it can often go straight through. And the RV is not very thick. You're talking only, a couple millimeters thick, not like the LV, which is much thicker. You got an LV that's a good centimeter thick at least. The RV apex, especially in these 90-year-old people, can be 3-4 millimeters thick, so you can go right through. So the big complication would be perforation, which
How would you know?
Yeah, I was about to say. So 2 ways. One would be abrupt loss of capture. So if you had capture and then all of a sudden you had nothing, basically, no matter what you're doing, you can't get capture. And often they'll go into tamponade. So hypotension, that's as a uncommon but fear complication of putting one of these in. The second was pneumo, obviously, when you're inserting the line itself. And a lot of times you don't have time to assess your line before you're already putting this in. So ideally you get a chest x-ray, make sure you're assessing your line. You're not going to probably have that luxury in an emergency setting. So if you get blood back, then you're good to go, basically. And if you don't get blood back, but you can flush easily, often what's happening is you're walled on the catheter, so the catheter is sitting next to the vessel wall. So if you pull the catheter back a little bit, just a little bit, maybe a centimeter or 2, you can often get it off the wall of the vessel, and now you can get both drawback and flush, basically. So that's often what we'll see as well. So, and if you think that you've perfed because you've got severe hypotension that's not responding to anything, then you guys have the bedside echoes in the ER to look for. And then if that's what you've seen and you see a rapidly accumulating effusion, then you need to do pericardiocentesis, which we won't cover today.
Sorry, I have a
Yeah.
question. Is there any contraindications, like for CHF patient or some other patient?
There is pretty much no contraindication to putting a emergency temp wire in, because basically if you're putting one in, they've already got something that's life-threatening. So things you want to be on the lookout for is if they have dialysis access. So you want to avoid a dialysis access site as much as possible, because one, that vein is going to be arterialized, so you're going to get brisk bleeding out of that vein to begin with. And second, you'd like to preserve as much dialysis access as possible. And third, often they have stenotic regions when they've had dialysis access. So if somebody's come in, they've had like 6 lines placed on one side, I do not want to go on that side because the likelihood is you're going to have some type of stenosis somewhere in there that you're going to run into and cause a serious problem. Yeah.
You still are not in a code situation, but say somebody had a toxicity or something that was going to be short-lived, you still use the external defibrillator, and what would be the cutoff of when you would do
So
this versus?
transcutaneous pacing. So to transcutaneously pace somebody for more than a few minutes is very painful.
You know, we used to sedate them and do it for a few hours.
If they need transcutaneous pacing, they need transvenous pacing.
Okay. That's-
So transcutaneous pacing is not going to be very effective. You lose about 90% of the energy through basically the impedance of the chest wall, the lungs, and all that. So
So we
only
don't
about
do-
10% of that energy is making it to the heart, which is why it's not very effective. And let alone if they're obese, then you're going to lose even more than that. So often you're not going to get any capture transcutaneously, basically.
They're feeling the shocks. Is that what you mean by
Yeah.
the pain?
Yeah, they feel it.
Yeah.
Yeah.
So they're literally just feeling
They
that
feel
free.
because so they're feeling the muscles tensing every time because it's basically activating the pectoralis, all the intercostal muscles, all of them are being activated. So they're twitching basically, and I've never had it done to me, but it looks horribly painful and people don't like it.
So can you address, Dr. Schwartz, when we are transcutaneous and we're then transition to transvenous, because that's our usual situation.
That becomes a lot more challenging. So this is when you've got 2 pacemakers, and we've had situations where you've actually got 3 because you've got a patient who's never followed up for a pacemaker check and their battery is very intermittently working or dead. And that's sometimes firing. You've got transcutaneous pacing, and now you're trying to transvenously pace. So you've got 3 pacemakers all trying to fire at the same time, which can be very complicated. So the best thing to do for transcutaneous pacing is first assess that they are really transcutaneously paced. So make sure you've got good mechanical capture, you've got a good pulse. The next thing to do that is, so you want to set your pacer here to 2 times the rate that the transcutaneous pacing is at. That is the best way of doing it. So if you have transcutaneous at 40, then you set your transvenous at 80. That way they're on a 2-to-1 basis, basically. So every other beat, you'll be able to assess whether or not your real pacemaker your transvenous pacemaker is actually working in comparison to your transcutaneous.
Will they compete with each other now?
So this one's, unless you set this one to an asynchronous mode. So if you set this one to an asynchronous mode, remember the asynchronous means that it's not looking at all, it's basically just pacing completely. Transcutaneous pacing is always asynchronous, okay, for the most part. So then you've got 2 asynchronous pacers, and then they will compete with each other. They'll both try to pace, and they won't both capture because the heart can't take 2 impulses back to back, basically, like that. So that's why it's best to just set one to half the rate as the other. That's the easiest way of doing it.
And once we confirm this is working, then we turn off our.
Turn off, yeah, so if you've got a good idea that this is working, just turn off the transcutaneous pacing, and that way you can really assess it very thoroughly. So to do all your testing on this, so once you think you've got capture, but you want to assess everything, turn off the transcutaneous pacing, because it makes your life a lot easier.
Now, you had mentioned one of your complications is when there is already a temporary in and you're putting a permanent in. Does it go the same way for us in the ED if they have a permanent in that's not working?
No,
Putting a
so if
temporary in?
no, so if they've got a permanent in, it's most likely an old device. It's most likely, that would be like a lead fracture. So if somebody comes in with an acute lead fracture and they're no longer pacing because their lead is fractured, then no, I mean, at that point, you're not going to run any further risk of putting the transvenous in because there's already a transcutaneous in. You may run into problems with access though, because often You want to avoid the side that I've already put the pacemaker in or somebody else has put it in, because that could be occluded. About 20% of people who get a permanent device will occlude their vein over a period of months to years, asymptomatically. So they won't have swelling on their arm, but they'll occlude their vein anyway. So if you see a permanent in this side, you want to go other side, almost certainly. Other questions about insertion? So the next thing I was going to talk about is who needs them. Pretty much it's going to be people who are symptomatic, almost always. So they come in with a pulse of 35, but they're not symptomatic at all. You don't necessarily need to put the temp wire in those people. I will often advocate for putting the access in those people. So the access often takes the longest amount of time for people. The temp wire you can throw in literally a minute or so, but the access, people won't get ultrasound, they don't need to clean the area and everything like that. So I always often advocate for, if they're in complete heart block, you want to assess it in two different ways. So complete heart block, is the escape narrow or wide? So if it's a narrow complex escape, that usually means it's a junctional. So if the QRS is narrow, that usually means it's something from the junction. Those are pretty reliable. So if they're in complete heart block with a narrow complex escape, I don't even put access in them. So I would say those people are fine. You can put them in the SCU. They probably don't even need the ICU for those type of people. If they've got a Y complex, then that's completely different. So if it's a Y complex, you want to see, did they previously have a Y complex rhythm? So if they didn't previously have a Y complex rhythm, now you're talking about that this is some type of idioventricular escape. So it's something coming from the bottom of the ventricle that's not going to be reliable. So those people at very least need access, and very well may need temp pacing as well. So you need to assess their symptoms. If they're short of breath, if they're having chest pain, if they're diaphoretic, those are symptoms, okay? If they're passing out, well, that's clear cut, you know? So that's those people. Another group of people you're going to see are people who are sinus node dysfunction. So they're having long sinoatrial pauses, and they pass out. So those people need it as well, because they're, sitting them up on the floor and letting them pass out for 10 seconds 4 times over the next, 8 hours. It's not very fun for the patient at the very least. And second of all, yes, almost always something's going to start up again. It's very rare for somebody to just go asystolic and nothing kick in. But it can happen, and you don't want to be in that situation where you have to emergently try and get something at that point. So if you're seeing big sinoatrial pauses, give them a temp wire. If you're seeing a new Y complex rhythm with complete heart block, obviously, go ahead and give them a temp wire. So the people who I would just get access on will probably be complete heart block patients with narrow complex escapes with no symptoms at all. Okay.
What about second degree?
Second degree, you don't need to temp pace them for the most part. So second degree, most of those patients you're going to see as what we call 2-to-1 AV block. So they're going to have 2 P waves for every 1 QRS. So those people you probably don't need to temp pace them, but you just want to watch them carefully, because often when they sleep, they'll go to 3-to-1, 4-to-1, 5-to-1. So instead of being every other beat, now you're going to have 5 P waves with a QRS, and those people you got to watch a lot more carefully, basically. So I put them in, at least in the SCU. If that's what they're coming in for, they came in for passing out, and you see 2-to-1 AV block, they probably need to be at least in the SCU, if not maybe the ICU, because they're likely going to have something more. I mean, if you're seeing heart block on the monitor and somebody's coming in for something that sounds like syncope or dizziness, then the likelihood is at some point they had something stronger than what you're seeing right then. And that is going to likely occur again, and most likely at 3 o'clock in the morning when nobody's ready to deal with it.
So Eric, what is the current process, depending on location of the patient,
Sure.
as to who, why, when, where this is going to be done?
So luckily I don't think I've ever seen one on the floor in the 6 years I've been here. Now, of course, there will be one in like a day. But most of them, 98, 99% of them are going to come into the ER. So we just changed the process to get these put in because we didn't have everyone who was able to do them. Not all the cardiologists actually do them all that much anymore. So some of them had to actually remove it from their DOPs because they didn't do them that much. Because if you've got, let's say, 30 cardiologists in the hospital, each of them are on call one every, let's say 7 nights or something like that, and you only get a pacer once a month, and they may go years without doing one, basically. So the new process that we put in is if somebody comes in and you think that they need a temp wire, is the first call would be to, well, I mean, if it's not clear cut, you know. The first call will be to the on-call cardiologist to discuss, do I think that this person needs to have a temp wire? If they confirm this person needs a temp wire, then the ER should immediately call the ICU and let them know, I'm putting in a temp wire, okay? So that way the ICU can assess what they're kind of having to deal with at that moment and come down and assist, basically. So the ER doctor can certainly try the first time. The ICU doctors are all also trained and all comfortable in doing them, so they could come down and assist you. If both ER and ICU are unable to pass them and get adequate capture, then the next call would be to the HAL line to consult with the interventional cardiologist. Don't just call and activate the HAT team. Call, ask to speak with the interventional cardiologist, say that we need a temp wire under fluoro, and they will tell how to activate, they will tell how to activate the lab, basically. That way it's not a
So they're going to do it in the lab?
Yes, then we use fluoro. So if you can't do it at bedside, and the ICU can't do it at bedside, then we're going to use fluoro in the lab.
And the good thing is at 3 o'clock in the morning, so many of the interventional cardiologists live in Howard County that they're close.
Well, they all have to be within 30 minutes anyway. And the reason we really changed the process is because a lot of times minutes make a difference. So if the general cardiologist, there's no requirement for how close they live to the hospital. So they could be 45 minutes away. So if they're 45 minutes away, that's too long to wait with somebody who needs this badly. The interventionalists who are on STEMI call tonight have to be in within 30 minutes.
So I think just adding, so for SIMS, mostly we don't mess with
No.
this loveliness, but we do go to rapid responses, and occasionally there's a STEMI on the floor or somebody who needs this.
Yeah.
Obviously, the ICU is our best friend in this situation, but we have had cases where people call the cardiologist on call, and like he's saying, they'll try to help, but you really want to remember the HAT team gets you the interventional cardiologist who would be in charge of coming in person and helping with this. So just be aware of that as the folks you have at even in the middle of the night.
Yeah, so same as Mindy was pointing to. If you have somebody who you think has a clear-cut STEMI and you're like, this is clearly an ST elevation, then you could call the ICU and then call the HAT team directly, and they can look at the EKG. You could certainly call the on-call cardiologist and we can assist, but ultimately it's going to be the interventionalist who comes in.
If you're having problems placing, is there an opportunity to use external ultrasound to visualize?
You won't be able to see it go through the heart, no. We can barely see the permanent leads on echoes when they're sitting in there, they're there, let alone this, which is smaller in diameter to a permanent wire.
Well, and just to stress, if our patient's in trouble, we always have transcutaneous as our backup.
You always have transcutaneous. Just always with transcutaneous, as I said before, the life pack is always going to look like you got capture, but you got to make sure you're actually assessing whether you actually have capture, because it's always going to look wide, and you're going to see this big spike. And I see plenty of people come in, they're like, "Oh, we got capture." I'm like, "That is not capture, basically." So you really want to assess that they've got good capture on because transcutaneous maybe 50-50 works.
Yeah, the majority of the time that you're doing this quickly, you're not getting transcutaneous capture.
Correct. That's why you're doing this that quickly.
If you can get the nice capture with transcutaneous,
Buys you some time. Yeah. No.
And while you're waiting, you can also, and you're not able to pass it, you can leave the porters in place.
Yeah, so if the tips, if you can't pass it, is to take out the whole thing, okay? And then make sure your curve is right, and then go back in again, okay? And then if you still can't do it and you're waiting for somebody else, get a new kit. Because once these hit body temperature, the curvature, you kind of lose it a little bit. So grab another kit, This is not cost-saving time, So you grab another kit where the curve is nice and fresh again, and then you try again with a new kit. And that's often, if I'm coming in and somebody's already tried 4 times, I'm not even bothering with what they've used. I'm getting another kit, basically, and trying a fresh one.
That's the other point, in that kit, there's a little end cap, so that when we do remove this wire, it can continue to use the introducer as an access line.
Oh,
You have
these
to
things.
put the end cap
Yeah.
on, the end cap on there, because you've already punctured that diaphragm.
It's no longer sterile, yeah.
Yeah.
Yeah, I don't know where it is.
Yeah, they always get.
Oh, here it is, yeah.
Yeah, they always get thrown away.
which brings up another, and the other port. How do you address that prior, during, after?
It should be flushed beforehand because there's air in there, obviously. And then when you draw back, you're going to draw back into there, so you want to flush through, that way the blood doesn't come
So
stagnant
you
and
usually
clot.
recommend flushing that before you even start your procedure?
Yes, you should be able to flush through with the 10th wire in here, especially if it's a 6 French. But if it's a 5 French sheath and a 5 French catheter, you're not going to be able to even draw back or flush through this side port once that's in there. But a 6 French, there's enough room to be able to get through.
Yeah, we really like that access to how we're doing.
Oh, yeah. It's just remembering to flush it before.
Yeah, yeah, you got.
I mean, most people will draw back anyway before they do anything, but.
I mean,
it's
listen,
nice
it
to
takes a
have
lot of
flush
air to
component.
cause an issue, obviously, in a vein. But you know, there's probably not more than, not even a cc of air, or maybe a cc and a half of air in that thing anyway. So that's it. Yeah, go ahead.
How often does it go into the PA like a small noise?
That's actually pretty hard to do, even when I'm trying to purpose. So when I put them in permanently, we put them in the pulmonary artery first, and then we drop them down the outflow tract and drop it into the RV apex. So imagine the RA, RV, and pulmonary outflow tract is kind of like a U basically. So we go up the U, and then we kind of walk it down and let it fall down into the apex. So it's actually very difficult to get it up into there.
Just
so,
because of the shape of the...
yeah, you know, you got to cross through 2 valves basically, and you got to come up the septum. So the likelihood is you would have stopped before you even got up there, because you would hit the RV septum, and you'd get good pacing on the RV septum. So you know, you're going to stop as soon as you see pacing. So as soon as you touch myocardium, you're going to get something good, and you're not going to push it any further. Unlike a swan, when you're pushing a swan, obviously you're looking at pressures, so you know where you are. This is 100% blind, basically. Other questions? And obviously, I'm always available. I might not be around, but you know, everyone has my cell phone number, and they can call me with issues, and people do. So you know, if there's ever a problem with one of them, you just give me a call, and I'll help out as much as I can. That's it. Thank you.
Thank you so much.